Welcome back to the Deep Dive. We're here to break down complex surgical knowledge, giving you the tools for real mastery. Today, it's all about the thymus. We're aiming for that professional-level command of its clinical and surgical anatomy. It's small, sure, but it's neighborhood. Vital.
That's spot on. We're not just covering the basics today. This deep dive is really for anyone needing to grasp the thymus, this small encapsulated bilobed organ right there in the anterior mediastinum, specifically for surgical planning. Think thymomas.
Right. We've pulled from the most detailed surgical anatomy sources out there. We're focusing on the kind of complexity you need for procedures like a full thymectomy. We need to dissect its changing shape, those very specific, sometimes dangerous vascular connections, the staging system everyone uses for tumors, and, the nitty-gritty surgical details that ensure safety.
And it is complex because it's so dynamic. I mean, the thymus changes dramatically over your lifetime. So the core question for us today is, how does this anatomy evolve? And crucially, what are those tiny details, the things that seem minor but are absolutely essential that you need to master to handle its pathology safely, especially when managing and staging thymoma? We're really aiming for total understanding here.
Okay, let's get into that life cycle. Starting with its big job early on in the immune system. This is key, right? Early life until puberty. That's when the thymus is doing its main work and is physically at its largest.
Yeah, the growth is pretty significant. At birth, it's maybe 10 to 15 grams, but it grows fast, usually hitting about 20 grams, maybe a bit more sometimes. And it stays that size through early childhood. It's really only after puberty that the functional decline, the involution, really kicks in.
And 20 grams, physically, what does that look like? We're talking dimensions here.
Dimension-wise, yeah, typically around 4 to 6 centimeters long, maybe 2.5 to 5 centimeters wide, and pretty consistently about 1 centimeter thick. So that's quite a decent-sized structure filling up the top part of a child's chest.
And in young kids, the shape is often described as more pyramidal.
Often, yes. But maybe more important, surgically speaking, is how far it stretches vertically. It can go really high, from the suprasternal notch right at the base of the neck, all the way down into the chest, maybe to the fourth intercostal space level. That big vertical spread is why getting full clearance, even in adults, means being really careful with those upper poles.
And then later in childhood, it tends to get longer. Right, so that top bit, the cervical part, isn't as obvious.
Exactly, it elongates a bit.
Then comes puberty, and involution starts. Now, this isn't just shrinking, is it? It's a fundamental change.
Oh, absolutely. It's a major morphological swap out. The functional tissue, the epithelium and lymphoid stuff gets steadily replaced by fibrofatty tissue. And that has real clinical consequences. The look changes dramatically. That vibrant, deep red color you see in an active young thymus, which stands out nicely against the yellow fat, it just fades. It becomes thinner, grayer, and honestly, in an older adult, it can be really hard to tell, apart from the surrounding mediastinal fat.
That change in color and texture must make a huge difference in imaging and during surgery. I mean, if it's involuted and looks just like fat, telling a stage eye tumor, which might also be surrounded by fat from normal tissue, must be incredibly tough, especially with minimally invasive techniques.
Precisely. You lose those clear tissue planes, that color contrast, so the surgeon has to rely much more heavily on anatomical landmarks, on careful dissection technique, rather than just visually spotting the difference between thymic tissue and fat. This is especially true if you're doing, say, a maximal thymectomy for myasthenia gravis. In that case, you need to remove every scrap of potential thymic tissue, even if it looks like fibrofatty remnant.
Okay, let's shift to the adult anatomy now. Where this remnant sits, up in the superior part of the anterior mediastinum. What's around it, superiorly and anteriorly?
So superiorly and anteriorly, the upper poles sit right behind those strap muscles, the sternohyoid and sternothyroid. And importantly, the thymus can reach way up, often connecting to the bottom poles of the thyroid gland. There's often a specific ligament, the thyrothymic ligament, linking them. So dissecting the upper poles, that's basically neck dissection.
And here's one of those critical details we need to master, that lateral asymmetry. Sources emphasize the left upper pole usually sits a bit higher than the right. What's the practical takeaway from that?
It's a really important clue when you're operating, especially with transcervical or VATS approaches. Knowing the left pole is likely higher tells you, okay, I need to expect to dissect a bit further up and maybe slightly more laterally on that side. It affects how you approach mobilizing that left pole safely from its attachments up high and, potentially puts structures on that left side at a slightly higher risk if you're not anticipating that extra reach.
And the crucial lateral neighbors.
Laterally. This is where it gets really close to some very important nerves. The phrenic nerves and the recurrent laryngeal nerves. They are right there. It's unavoidable. If the thymus is enlarged, maybe due to a thymoma, those nerves are immediately at risk of being pushed on or even invaded directly. The phrenic nerve, in particular, runs right over the side, just under the mediastinal pleura.
Let's talk posterior relations now, the great vessels. This sounds like the high-risk zone.
Oh, definitely. Posteriorly, you've got the main structures of the superior mediastinum, the trachea, the big vessels, and the pericardium covering the heart. But the single most significant high-risk relationship, that's with the left brachiocephalic vein, the LBCV.
That LBCV, it's a known challenge.
Yeah.
Usually posterior, but sources say it can be kind of integrated right into the thymus.
Yes, that's surprisingly common. You don't just find it nearby. Sometimes it's actually embedded in the back of the gland tissue itself, and occasionally it can even be completely wrapped around by the thymus. If the gland is large or diseased, just freeing up that LBCV safely is one of the hardest parts of the whole operation. Injury to it, especially a tear on the back wall, vascular control becomes incredibly difficult. Huge blood flow, deep location, identifying it early and safely is just paramount.
All right, section 2. Let's get into the plumbing and wiring. These details are absolutely non-negotiable for safe surgery. Starting with arterial supply, where does the blood come from and what's unique about how it gets in?
Okay, arterial inflow. Primarily, it's branches from the internal thoracic arteries, those run alongside the sternum, and also the inferior thyroid arteries. Less often, you might get a branch from the superior thyroid artery, but the really key technical point, the majority of this blood supply comes in via the upper poles.
So that concentration at the top means those first steps of mobilization, whether you're coming from the neck or through the chest, carry the biggest risk for significant arterial bleeding.
Absolutely. And what makes it trickier is that the thymus doesn't really have a defined hilum. You know, like a kidney where everything goes in and out one spot. Not here. The arterial branches are more spread out. They might run along the septa between the lobes, or they might just punch directly through the capsule to get into the tissue, often right where the cortex meets the medulla. This diffuse entry means you need really careful dissection, constant attention to hemostasis, especially when you're peeling that capsule off the top and sides. You can't just put a clamp on a single hilum.
Okay, let's switch to venous drainage. We already flagged this as having the biggest surgical warning. Where does the blood mainly drain to?
The veins mostly drain into the left brachiocephalic vein, the internal thoracic veins, and the inferior thyroid veins. Sometimes you might see direct drainage into the SVC, the superior vena cava. But that left brachiocephalic vein, that's the absolute bullseye for surgical concern.
Which brings us right to that critical common venous trunk. Can you explain how it forms and exactly why it's so dangerous?
Yeah, this is something surgeons just have to anticipate seeing. Very often, you'll find one or maybe more veins coming out medially from each lobe of the thymus. These little feeder veins then quickly join up to form a single, often quite short, common trunk. And this trunk empties directly into the back side of the left brachiocephalic vein. The danger. It's short, often quite wide, and it's in a really vulnerable spot. If you accidentally tear that trunk off the LBCV avulse, you create a massive hole in a major vein. It's low pressure, but the volume is huge. Immediate massive bleeding, and it's really hard to get to, especially if you're doing minimally invasive surgery.
So the surgical rule isn't just find the LBCV. It's find and securely ligate that common trunk before putting any real tension on the thymus itself.
Exactly. Non-negotiable. Early identification, careful isolation, then usually double ligate it and divide it. Only after that's done can you really start safely mobilizing the main body of the gland without risking that catastrophic tear. You often do this early in a sternotomy, actually. The LBCV is one of the first big things you see once you open up the front of the pericardium.
Moving to the lymphatic system. There's a really unusual feature here, an exception that's important for understanding advanced disease staging.
Right. This is a major difference from almost any other organ. The thymus fundamentally has no afferent lymphatics, meaning lymph fluid and cells don't flow into the thymus from elsewhere. Its main job is internal maturing T cells.
So no inflow. What about the outflow, the efferent lymphatics? Where do they go? This seems critical for understanding stage IVB spread.
Okay. The efferents, the exit routes, they start deep inside, in the medulla and at the junction with the cortex. They then flow outwards, following the blood vessels, and they eventually drain into a few key groups of regional lymph nodes. The brachiocephalic nodes up high, the tracheobronchial nodes near the airways, and the peristernal nodes, which run along the internal thoracic vessels. Knowing these drainage paths is vital because these are the first places lymphatic spread shows up, defining stage IBB disease.
And finally, the nerves. What's the deal with thymic innervation? Sounds complex.
It is pretty complex, comes from a couple of sources. You've got autonomic input, which controls things like blood flow and cell function. That comes from two main routes. The sympathetic chains, usually via the stellate ganglia or maybe the ons subclavia, and also parasympathetic input directly from the vagus nerves.
But there's also nerve supply to the capsule itself, which has its own clinical relevance.
Yes, exactly. The fibrous capsule, or maybe more accurately the surrounding tissue layer, gets sensory and motor fibers from branches of the phrenic nerve, and also from the descending cervical nerves, specifically the lower roots of the ons cervicalis. This connection is another reason why you always identify the phrenic nerve. It's not just passing by, it's actually supplying the area you're dissecting in. Its proximity is just constant, whichever way you approach the thymus.
Okay, let's pivot now to the pathology that really drives the need for this deep anatomical dive. Thymoma. Can you define the tumor and its place among anterior mediastinal masses?
Sure. Thymoma is generally a slow-growing tumor. It arises from the epithelial cells of the thymus. Now, while it's rare overall, if you look specifically at tumors found in that anterior mediastinal space, thymomas are actually the most common ones diagnosed. Their behavior, whether they're considered benign or malignant, depends a lot not just on how the cells look under the microscope, the histology, but really critically on how far they've invaded.
And to measure that invasion, we use the standard staging system Masaoka, modified by Koga, and now clarified by ITMIG, the International Thymic Interest Group. Why did ITMIG need to step in and clarify things?
Well, the ITMIC clarification was really needed because the original Masaoka system had some gray areas, especially around interpreting capsular invasion. It sometimes led to different staging decisions based on subjective calls. So the ITMIC system aimed to remove that ambiguity. It does a good job combining what the surgeon sees during the operation, the perioperative findings, with what the pathologist finds microscopically after the operation, the histopathology.
And what's the single core anatomical question this whole staging system is trying to answer?
Fundamentally boils down to this. Has the thymoma broken through its fibrous capsule? If it has, which nearby structures are involved? And was that breach only visible microscopically, or could the surgeon actually see it macroscopically? That difference between being contained versus having spread is really what determines the patient's prognosis and dictates the entire treatment plan. It separates a potential straightforward cure from needing much more complex therapy.
Okay, let's really nail down these stages for mastery, starting with stage I, the non-invasive one.
Right. Stage I means the lesion is completely within the capsule. Sounds simple, but the ITMIG clarification is key here. The tumor might show some microscopic pushing into the fibrous capsule itself, but as long as those tumor cells haven't fully broken through the outermost layer of that capsule into the surrounding fat tissue, it's still classified as non-invasive encapsulated disease. Stage 1. That's crucial for prognosis.
Then stage 2 is the first step beyond the capsule. It's split into IIA and IIB. What's the critical difference here?
Stage 2 means invasion has occurred. Stage IIA is defined by microscopic spread beyond the capsule. The pathologist has to confirm under the microscope that tumor cells have infiltrated into the fat or soft tissue immediately outside the capsule, sometimes called transcapsular invasion. The key is the scale. You can only see this evidence of spread microscopically.
And that distinction between I and IIA is huge, isn't it? Stage I might just need surgery, but IIA usually means adjuvant therapy too. How does a pathologist know for sure if a gap in the capsule is real invasion or maybe just, an artifact?
That's a really important point. The ITMIG guidelines are explicit. Just not seeing a capsule in one area, maybe the sample wasn't perfect, or there was old inflammation that doesn't automatically mean invasion. To call it IIA, you need positive, clear microscopic evidence of tumor cells actually in the surrounding tissue, not just a gap in the capsule wall. This is why handling the surgical specimen carefully is so important. You need that tumor margin well preserved for the pathologist.
Okay, escalating up. Stage IEB.
Stage IIB is defined by macroscopic spread beyond the capsule into the surrounding fatty tissue. This means the surgeon can actually see during the operation that the tumor has broken through its capsule and is growing into the mediastinal fat. But, and this is a critical but, that visible spread must not involve breaking through the pleura, the lining of the chest cavity, or other mediastinal boundaries like the great vessels. The fat involvement could be just a small spot or quite extensive, but the major neighbors have to be clear.
And if the tumor goes beyond just the fat and starts involving those neighbors, that takes us to stage 3, locally advanced. What structures specifically push it into stage 3?
Stage 3 means direct invasion of neighboring organs or structures. Common examples are the pericardium, the sac around the heart, the big mediastinal vessels like the SVC or aorta, or the lung itself. ITMIG clarifies this includes involving the mediastinal pleura or part of the pericardium. Critically, if it punches through the pericardium or through the visceral pleura covering the lung surface, or directly involves the phrenic nerve, that's all stage 3. Involvement of these structures obviously makes the surgery much bigger, potentially needing parts of those organs removed too.
Then we reach stage 4, disseminated disease, split into IVA and IVB. What's the difference between these two types of widespread spread?
Stage IVA means the spread is widespread, but still kind of local within the chest cavity. It's defined by finding separate nodules or foci of tumor on the surface of the pleura or the pericardium. It's like the tumor cells have seated themselves around the chest lining, often small, multiple spots.
In stage IVB, that's the most
Sure.
advanced.
Stage IVB represents true distant spread, either through the bloodstream hematogenous spread or via the lymphatic system. This diagnosis is made when you find involvement of distant lymph nodes like those brachiocephalic or peristernal nodes we talked about earlier, or sites outside the chest entirely, like bone or liver metastases. Or if you find tumor nodules actually within the lung tissue itself, not just on the surface, that's parenchymal lung involvement.
So the staging isn't just descriptive, it directly maps onto a treatment pathway.
Absolutely. It's a direct algorithm. Stage 1, usually just complete surgery, high cure rate. Stages 2 and 3. Because there's invasion, microscopic, macroscopic, or into local structures, it's almost always a combined approach. Surgery, often followed by radiation or chemotherapy to deal with any microscopic cells left behind. And stage 4. That's primarily managed with systemic treatments like chemotherapy and radiotherapy. Surgery might play a limited role, maybe for symptom relief by debulking, but it's not usually curative at that point.
Okay, let's bring all this anatomy into the operating room. We'll look at the 3 main surgical ways to perform thymectomy, which, as a reminder, is done for tumors, managing myasthenia gravis symptoms, or sometimes for access in cardiac surgery. Let's start with the classic approach for complex cases, median sternotomy.
Right, the median sternotomy. It's still really the go-to approach for the more advanced or risky situations. Think stage IAB, stage 3, maybe just very large tumors where you know or strongly suspect the vessels or other structures are involved. It simply gives you the best possible view and the most direct access to the entire superior and anterior mediastinum.
What's the key technical goal that a sternotomy really allows you to achieve properly, and how's it done?
The main goal it facilitates is a complete, thorough phrenic to phrenic resection. That means taking out the entire gland from the phrenic nerve on one side all the way across to the phrenic nerve on the other side. To do that safely, you typically need to open the mediastinal pleura on both sides. That lets you clearly identify both phrenic nerves vital to protect them and gives you the room you need to work safely around the great vessels. And crucially, this open approach gives you the best angle and space to find, dissect, and securely ligate that common venous trunk draining into the left brachiocephalic vein, all under direct vision.
Now, the more modern, less invasive alternative, video-assisted thoracoscopy, or VATS. What's its role now and what are its limitations?
VATS has definitely become very popular, especially for removing smaller, apparently localized thymic tumors. Generally, that means stage on, maybe carefully selected stage IIA cases if the invasion seems very limited. It uses small incisions, usually 2 or 3 ports, often done from the right side, which gives a good view of the whole anterior mediastinum with the patient positioned semi-supine.
But with that restricted VATS view, finding those critical structures must be even harder. How do surgeons reliably find the left brachiocephalic vein, for instance?
It is harder than open, no question. You typically locate the LBCV by finding its most reliable landmark, where it joins the superior vena cava, SVC. So the surgeon dissects medially, finds the SVC, and then traces it back proximally to identify that junction point. Once you've oriented yourself to the LBCV, then you have to meticulously find those critical venous feeders, clip them, and divide them. Often using specialized tools like ultrasonic shears or robotic instruments helps here.
What are the main drawbacks of VATS that means sternotomy is still needed for more advanced disease?
The main limitations really revolve around two things: vascular control and ensuring a complete reception. If you get significant bleeding, especially involving the LBCV, controlling it through small ports is extremely difficult. That often forces an immediate conversion to an open sternotomy. Also, getting a really thorough, clean resection on the opposite side from your ports can be technically demanding with VATS. Sometimes, if complete clearance is the absolute goal, like for myasthenia gravis, you might even need a second VATS procedure from the other side or just opt for sternotomy from the start.
And the third option, more specialized, the transcervical incision. What's its place today?
The transcervical approach, yeah, it has a long history. It's still useful, but mostly for removing thymic tissue when malignancy isn't the primary concern. Think thymic hyperplasia or for managing myasthenia gravis symptoms. Its strength is giving really good direct access to the upper poles of the thymus through a neck incision.
But the view downwards into the chest must be severely limited. How do surgeons manage that?
Right. Visualization down low is the challenge. The operation's done through a small cut above the sternum, like for a mediastinoscopy. You start by freeing the upper poles from behind the neck muscles. Then, to get the rest of the gland out from down in the chest, you absolutely need specialized equipment. The key is usually a Cooper's thymectomy retractor. This device physically lifts the sternum forwards, creating a working space and improving the view down towards the inferior poles.
Okay, let's synthesize the hazards. The absolute mastery checklist for keeping patients safe. We have to prioritize the nerves.
Nerves first, always. The phrenic and the recurrent laryngeal nerves are the highest risk structures, period. Surgeons absolutely have to stick to nerve-sparing techniques. That means avoiding heat injury from diathermy right near them, especially where they run along the side of the capsule. If you get bleeding near a nerve, the safest bet is usually to carefully oversew the vessel or use clips. Aggressive cautery is just too risky. It can cause delayed thermal damage and paralysis.
And where are the specific hotspots to watch for these nerves?
The phrenics need to be found on both sides during the lateral dissection. Watch them running across the sides of the gland. The recurrent laryngeal nerve that controls the vocal cord is most at risk during the dissection of the upper poles. It's also particularly vulnerable if the tumor is growing upwards into the aortopulmonary window area, which you sometimes see with more invasive tumors.
Now, the vascular risks, especially that left brachiocephalic vein. Remind us of how injuries happen and the mandatory prevention steps.
The big risk is iatrogenic injury, meaning caused by the surgery itself. Usually it happens either by tearing off that common feeding vein during mobilization, pulling too hard on the thymus before the vein is secured, or it can happen if the tumor is really stuck onto the LBCV, making it hard to see the plane between them.
So the safety checklist for the LBCV is essential for every single case.
Absolutely essential. Step 1. Identify and dissect out the LBCV early. Find it either by carefully dissecting between the lobes or by tracing it back from the SVC junction. Step 2. Find that common venous trunk specifically, double ligate it, divide it first. Step 3. If you encounter that anatomical variant where the thymus actually wraps around the LBCV, you have to be incredibly meticulous. Make absolutely sure the vein is completely dissected free from that encircling tissue before you start cutting the gland away. Otherwise, tearing the vein is almost guaranteed.
And finally, that risk of arterial bleeding from the upper poles.
Yeah, since most of the blood supply comes in up top, you need good hemostasis during that superior dissection, especially if you start with a neck approach. Those arterial branches can be short, and if they get torn, they can retract back into the nearby tissue, making them hard to catch and control.
Okay, let's put this elite knowledge into practice. Clinical case. 40-year-old male found to have an asymptomatic, small, apparently well-encapsulated thymic tumor, mostly on the right side. Looks like a classic stage I. How do you approach the surgical decision?
Okay, so presumed stage I, small, localized. The minimally invasive VATS approach would likely be the preferred first choice. It offers faster recovery, better cosmetics. However, a median sternotomy is always a solid, reliable alternative, giving comprehensive access. It might be preferred if the surgeon isn't as experienced with the complexities of a full VATS thymectomy, the transcervical approach. Probably less ideal for a definitive tumor removal like this unless you have that specialized retractor system readily available and are confident you can get adequate clearance, especially on the contralateral side. It's more challenging for oncologic margins.
And no matter which approach is chosen, the patient needs a clear discussion about the risks based on the anatomy we've just mastered. What are the absolute must-mention risks?
You absolutely have to warn the patient about potential phrenic nerve injury. That could lead to diaphragm problems, breathing difficulties. You have to mention the risk of a hoarse voice, from potential injury to the recurrent laryngeal nerve. And of course, the risk of significant bleeding or vascular injury, specifically mentioning the left brachiocephalic vein, and the possibility of arterial bleeding from the upper poles. And crucially, if VATS is the plan, you must include the possibility of needing to convert to an open sternotomy if things get complicated, like uncontrollable bleeding. Discussing risks at this level of anatomical detail, that's what defines professional informed consent. #outro.
So we really covered the ground today. We've mastered the anatomical journey of the thymus from its dynamic changes over a lifetime that shift to fibrofatty tissue to pinpointing details like the left upper pole's higher position. We've hammered home the critical importance of handling that common venous trunk before applying any traction. And we've dissected the subtle but crucial clinical differences between stage I encapsulation and stage IIA microscopic invasion under the ITMIG definitions.
Exactly. And achieving mastery really comes down to understanding the so what behind these details. Knowing the recurrent laryngeal nerve is vulnerable up high, while the esophagus is generally safer posteriorly shielded by vessels that gives you real confidence and orientation during surgery. And recognizing that just seeing separate spots on the pleura instantly changes the game to stage IVA. It shows how much prognostic power is packed into every millimeter of potential tumor spread.
It truly demands an elite level of anatomical knowledge. Now, for our final provocative thought for you, the listener, to take away and explore, we spent a lot of time confirming that the lymphatic drainage goes to specific node groups, brachiocephalic, tracheobronchial, peristernal, and that stage IVB involves spread to these nodes. So, thinking beyond just removing the primary tumor, when treating advanced stage IVB disease, what further steps, what systematic explorations, or maybe even lymph node dissections might be needed to truly clear all those potential disease pathways within the mediastinum, beyond just the immediate area of the thymus? That challenge of comprehensive nodal clearance, that's really pushing the edge of surgical oncology in this specific area.
Definitely something to think about. Thanks everyone for joining us on this deep dive into the thymus.
We'll catch you next time.